Good afternoon, everyone. We'll be starting in just a few moments. Thank you for your patience.
All right. Good afternoon, everyone. Old Dominion's Office of Community Engagement and the College of Health Sciences are pleased to welcome you to Weathering the COVID-19 Storm, exposing longstanding health inequities for Black Americans and creating a call to action. I'm Valika Gatling, the Director of Diversity Initiatives at Old Dominion University, and I have the privilege of moderating this panel of dynamic women in the field of equity, diversity, healthcare, policy, public health, and sociology. Before I introduce the panelists, I want to remind you that we will open the discussion up to audience questions later in the program. Please submit your questions through the Q&A section down below. Today's panelists are going to feature two guests, Dr. Janice Underwood and Ms. Sable K. Nelson. Before I introduced Dr. Janice Underwood and Mrs. Sable K. Nelson, I would like to introduce our special guest that we have from Old Dominion University. And I'll start with, we first have Dr. Kimberly Adams Tufts. Dr. Adams Tufts is a professor of nursing, and she has an extensive history of working to address healthcare and health inequities. She was the founding director of many, has been the founding director of many community-based primary care center and free standing birth center designed to address these inequities in older adults, pregnant women, and children who live in underserved inner urban neighborhoods in Cleveland, Ohio. She has also designed and implemented the federally sponsored Healthy Family, Healthy Start curriculum for the Cleveland area community health workers. She then moved to address inequities for people living with HIV in the United States and abroad, spending several years advocating for the George W. Bush's administration's passage of the initial President's Emergency Plan for AIDS relief, which paved the way for providing more equitable access to the life-saving antiviral therapy for people of color. Dr. Adams Tufts then moved to higher education and has spent considerable time introducing students to the challenging issues presented by healthcare inequities so often experienced by people of color and the negative health outcomes commonly known as health disparities. Welcome, Dr. Kimberly Adams Tufts. Our next panelist is Dr. Mona Danner. She's the professor and chair of the Department of Sociology and Criminal Justice at Old Dominion University, with extensive expertise in social inequalities, crime control policies, and globalization. Her teaching focuses on the distribution of socially valued resources to different categories of people by race, class, and gender across social institutions, and the ways that the social structure influences social interactions and individual behavior. She has presented at conferences throughout the United States, Europe, Latin America, Australia, and at the NGO Forum held in conjunction with the 1999 United Nations Conference on Women in Beijing, China. In addition to scholarly publications, Dr. Danner has published op-eds, been featured on television, radio interviews, and has been quoted by the popular print media more than 30 times. Welcome, Dr. Danner. Next, we have Dr. Leslie Hoagland. Dr. Hoagland is a clinical assistant professor of public health in the School of Community and Environmental Health. She is the former director of the Division of Population Health Data at the Virginia Department of Health. She has 20 years of experience providing strategic vision and collective impact leadership to improve public and community health. She approaches public health as a social epidemiologist to eliminate food deserts, champion health equity, and dismantle systems of chronic disadvantage. She also evaluates public health workforce capacity, skills, resources in local and state government to respond to special and common population health events and concerns. During the COVID-19 pandemic, she has published several articles and has been activated by the Virginia Medical Reserve Corps for contact tracing and N95 respirator fit testing, monitoring diagnostic testing for disparities among racial, gender, age, and health statuses. Welcome. Our final panelist for today is Dr. Jamila Martin. Dr. Martin is an assistant professor of nursing in the College of Health Sciences at Old Dominion University. Dr. Martin's scholarship focuses on community health nursing education, community initiatives, nursing research pedagogy, social determinants of health and health disparities, She is an American Association of Colleges of Nurses nursing grant recipient, and her leadership on the Interprofessional Population Health Learning Hub and a HRSA award recipient for her work with veterans in primary care to address substance use disorders, telehealth, mental health, and social determinants of health. Welcome, Dr. Walker. And as I mentioned earlier, we have two special guests, Dr. Janice Underwood and Ms. Sable K. Nelson. Dr. Underwood was appointed by Governor Ralph Northam at the Commonwealth as the Commonwealth of Virginia's first cabinet level chief diversity officer. This position is also the first of its kind in our nation. As the Commonwealth's chief diversity officer, she is committed to addressing racial, ethnic, disability, gender-based, and other cultural inequities in formal and informal policies and practices in Virginia state government. As a result, Dr. Underwood is working tirelessly to build the One Virginia statewide strategic plan for inclusive excellence across over 100 state agencies and with public and private sectors. In her short tenure, she has been named one of 20 Women of Change for 2020 by the Virginia Museum of History and Culture for the accomplishments and impact she has already had across the Commonwealth. Her goal is to make Virginia an exemplar for the nation regarding diversity, equity, and inclusive excellence. Prior to her appointment, Dr. Underwood served as Old Dominion University's Director of Diversity Initiatives and as the chair of the President's Task Force on Inclusive Excellence. Dr. Janice Underwood is also a proud member of Alpha Kappa Alpha Sorority Incorporated. Welcome, Dr. Underwood. Our next panelist, a wonderful monarch, welcome. Our next guest panelist, Dr. I want to put a doctor on everything, but we got a JD on this one, is Ms. Sable K. Nelson. She is a licensed attorney and public health policy expert specializing in research, communications, and training in healthcare policy and legal analysis. Ms. Sable K. Nelson is currently the acting office director for the Virginia Department of Health, Office of Health Equity. She also holds the role of the Virginia Department of Health representative on the Health Equity Leadership Task Force for the Health Equity Working Group during COVID-19. Ms. Sable K. Nelson remains engaged in local, state, and federal HIV, AIDS, STI, and reproductive justice advocacy campaigns, base building, training, and educational initiatives, as well as technical capacity and building assistance. She is an active member of Delta Sigma Theta Sorority Incorporated, as well as the NAACP National Board of Directors, with a devotion to social justice and a passion for politics. And I breathe. Oh, what an awesome panel of guests that we have today to address this important topic of weathering the COVID-19 storm. Welcome, ladies, again. So as we were having our introductions and just prior to everyone logging in, we did have a poll, and at this time, I'd like for us to see the results of our initial poll. And as those come up, just wanted to remind everyone that collectively, Black Americans are nearly 13% of the population in the United States, but they have suffered 24% of known COVID-19 deaths. They are dying at almost twice their population share. Black Americans are overrepresented in COVID-related deaths in 30 states and Washington, D.C. The next slide that we're going to see gives us a peek at some of our recent data from the Commonwealth of Virginia and the city of Norfolk. And I would like to yield at this time to allow Dr. Holland an opportunity to talk a little bit about this particular data set.
Thank you so much, Dr. Gatling. So COVID-19 has made it very plain and very clear that racism has brutally undermined everyone's public health and positioned ethnic and racial minorities to suffer the worst effects of this crisis. Certainly the pandemic has exacerbated and the disparate, already known social and economic impacts on Black Americans through increased unemployment, low-wage essential workers, loss of small businesses. And when we think about the conditions and factors that play into the COVID-19 disease transmission and what those underlying health conditions and factors are, and who in the populations of greatest risk or greatest prevalence, those with asthma and chronic kidney disease, lung disease, diabetes, obesity, serious heart conditions, the reality is very clear and action is desperately needed. So overall, COVID-19 cases and hospitalizations and deaths impact a disproportionate number of Black Virginians as compared to white Virginians per 100,000. The Black case and hospitalization rates are double that of white case and hospitalization rates in Norfolk, and they exceed the Black case and hospital rates for all Virginians. Black residents in Norfolk die 4.6 times more from COVID-19 than their white counterparts, whereas Black Virginians die 1.3 times more from COVID-19 than white Virginians overall. An important note about this data, while the disparities and inequities are here before you, and numerically, 32% of our COVID-19 cases do not have reported race with them, and that's 19% of cases in Norfolk as well. And so when we have incomplete racial data, it does make it difficult to understand the full scope of the problem and the extent to which all populations are affected, and especially those most affected.
Thank you so much. As a lead into our discussion, we'd like for you to take just another moment to consider another polling question. The discussion that we're going to have will look to search to confirm the answer that you selected, or it may open your mind to some additional ways to look at the problem. So I'll give you a few moments to respond to this particular question. Okay, we see there our panelists. You all can see some of those responses there. The ones at the very bottom there yielding the most responses there. Thank you so much. All right, well, let's jump right in. And before we get started, I would like to ask Dr. Adams-Tufts if you could get us kind of started. And if you would define the origin of the concept of weathering and how it relates to the COVID-19 pandemic.
Thank you very much. Yes, I'd like to talk a little bit about the historical perspective of this. And I see that my video has gone out, and sometimes that happens. So I was just going to talk ahead. Let's try that again and see if it's come back. There it is. All righty. So yes, traditionally, I'd like to say that as healthcare providers in general, and also in public health, and I would also say sociology, we were taught that core risk factors for certain diseases centered on individual factors. One primary risk factor that we often talked about and were taught, socialized into thinking was very important, was individual behaviors. Things such as diet, not eating the right things, smoking, risky sexual behaviors, generally not taking care of self. Things such as health literacy. Oh, if they only knew more, they'd do better. And also the concept that race is biological. instead of the social construct that it is here in the United States. And if we thought that race was biological, we could then go down the line logically and conclude that there was something inherently wrong with African Americans in particular. Most brown and Black people, but African Americans in our context in particular. So that's historically where we started from. And then, though, as we moved along in the last 30 years or so, we began to look at other variables. For example, 1999, the American Journal of Public Health, there was a classic article published telling we researchers and investigators to stop looking at race as a variable or something that causes a change, that causes variance in whatever issue we were looking at. And we began to talk about things such as social determinants of health. Our federal government says this, and we all say this now: where people live, work, and play has the greatest influence on their health outcomes. So when we talk education, it's not health literacy, but it's formal education. We can also talk about the impact of good housing on people, the impact on neighborhood environments, such as green space or lack of green space, environmental exposures and such, safety issues, food security. I could go on and on. And then let's not leave out systemic and structural racism. And so all these things, these factors lead to a stress that's there and underlying and daily in the lives, particularly of African Americans, because we have some new studies out in the last few days that show it's African Americans. This day-to-day stress leads itself to some biological consequences. And one of them is, for example, the chromosomes that we have in our DNA. They are protected on the ends by these caps called telomeres. Well, all this stress leads to a wear and tear. And we now know from science that the telomeres begin to shorten. What does the shortening mean? The wear and tear, the weathering, the wearing down. It leads to an accelerated biological aging in African American populations. The other thing that biologically happens is having elevated levels of stress hormones due to those microaggressions that African Americans face every day also relates to having high underlying levels of stress that lead to some of these conditions we all talk about: cardiovascular disease, high blood pressure, diabetes, heart disease. When I say heart disease, heart attacks and strokes, asthma, go on and on. And so these stresses result in an accelerated biological aging. And that is what weathering is. And we now know that despite your income, your profession, all these social factors, you're a rich African American, you're still going to be more likely to get COVID than someone who's poor, who's not African American.
Okay, thank you. So Mona, I wanted you to expand. We talked about, as we were having this rich discussion a couple of weeks ago, about some comments that were made by the Surgeon General, early on in this pandemic, and how he alluded to the factor. He said that, drugs, tobacco, and alcohol, that Black Americans should avoid those. And so based on what Dr. Adams-Tufts just shared, do you believe these comments are helpful or harmful, or why? Can you expound upon that a bit?
I think we would all agree that everyone should avoid harmful substances such as drugs, tobacco, and alcohol. But to place that as an individual level sort of blames the victim of health issues. What we know is that it is not an individual level problem, as Dr. Adams-Tufts just discussed, that it is systematic racism that is so problematic for African Americans and all people of color in the United States. And when I talk about systematic and structural racism, I want to make it very clear. It includes those microaggressions that individual people experience and that are predicated upon them by other individuals. But of a far greater importance are those practices and policies that are institutionalized, that are historical legacies and contemporary realities of racism and as a result of our long 400 years of racist history in this country. And let me just give one example. Dr. Adams-Tuff talked about how important where we live, work, and play is. We know that so much is down to where we live. Our homes, where are our homes? Because our homes, and what are our homes like? And one of the things we know is that it has been the practice and the law for most of the US history to practice residential discrimination, to segregate on the basis of race. It was in fact built into the original policies in the 1930s that opened up home ownership to Americans in the United States, but really only to white Americans. And so it kept those benefits for whites and locked out African Americans. Home ownership is important because home ownership is about where you live. And then that's also about what kind of opportunities are where you live. Both the quality of outdoor space, the safety of outdoor space, the quality of schools. And schools then have such a huge impact in terms of later life opportunities and chances, such as education and later education and jobs. And home ownership helps build wealth. And African Americans have largely been locked out of home ownership. They have dramatically lower rates of home ownership, and that also means they have less wealth. For every $100 of wealth held by white families, African American families have $7. That means they don't have the opportunities to pass on wealth and improve life chances to their children, as well as they don't have the safety net to help them through difficult times.
Okay, thank you so much for sharing. I wanted to now go to Ms. Sable K. Nelson, because I know that in the work with the Health Equity Task Force, that many of the concerns that have been expressed by Dr. Danner and by Dr. Adams-Tuff, have risen to, have been on your radar, and you all have been working to decrease some of the barriers, some of the inequities that have been seen. And so would you take a few moments there to explain the role of the Health Equity Task Force, and have there been any barriers that have been identified that you feel will evoke policy changes specifically to perhaps some of the things that Dr. Danner just spoke of?
Absolutely. So a little bit about the Health Equity Leadership Task Force. One of the things that the Commonwealth of Virginia has done in its COVID-19 response is for the first time embed a health equity mechanism in its unified command. And our leadership task force consists of the equity experts in each of the major partnering agency within the response. So the governor's office representative is Dr. Janice Underwood, who reports to the governor. We have VDEM representation through Curtis Brown, as well as through Dr. Lauren Powell, who has been hired as a health equity expert. And I am the director of the Office of Health Equity, and I am the VDH representative. And this leadership task force oversees and tries to operationalize the recommendations from our larger health equity working group. We have now over 100 individuals who participate in our weekly calls, where we seek to apply a health equity lens, both proactively and reactively, to every aspect of our COVID-19 response. And to date, our activities and accomplishments have primarily focused in 3 buckets. We've been, in terms of like some of the barriers that you talked about, we've been trying to make sure that we effect meaningful change in 3 areas. So we have equity education. We realize that a lot of people understand or utilize or think that they understand and utilize the term equity, not really understanding what it means, and especially not knowing how it applies to their everyday work. So what we've done is developed the equity training video that's been used across the state agencies. And also we have been able to do some community engagement work as well. We've reached over 25,000 residents of the Commonwealth of Virginia through various types of town halls and community trainings. And we also have a pilot initiative, because one of the things that we know is that a lot of people who would but especially Black individuals, may not have had access to sanitation or to masks, for example. So what we've been able to do is leverage an incredible tool through Deloitte, and we're able to leverage the VDH data and the Deloitte data to find out where the populations who are most vulnerable to COVID-19 and overlay that. And we're able to work with localities to get masks and sanitizer into those most vulnerable communities that are truly having difficulties because of systemic oppression and racism. And we've also been working with internal collaborations. We know that resource investment is important, and we've made sure we've met with all of the agencies across the Health and Human Resources Secretariat to consult with them for their CARES Act proposals to make sure that they were prioritizing equitable funding and prioritizing communities that were most vulnerable to COVID-19 and that were most disproportionately impacted, especially the Black community.
Okay, thank you. And you mentioned the 3 buckets. You said education, because I know that's been, yeah.
Equity education, community engagement, and internal collaborations.
Okay, thank you. Thank you so much. We had a question wanted to clarify that. Thank you so much. I appreciate it. And so when you think about those 3 buckets, and I'll now go to Dr. Underwood. When you think about those 3 buckets, I want to talk a little bit more, if you could talk a little bit more as it relates to some of the barriers to some of the policies that you have, you and or your teams have identified that really need attention. And, what would you suggest that those in localities pay close attention to as they seek to understand the difference between equality and equity?
Well, thank you so much. And it's good to be with my Monarch family. To Dr. Danner and Dr. Adams Tuff's point, and really if I could just take us back a second to that poll we just saw, it asks us to identify why there's a disparate impact in the Black community. I saw that the highest numbers were for systemic racism and underlying health conditions. And so I would just almost assert that underlying health conditions is a subtle way of saying systemic racism, because that's what I kind of felt like Dr. Danner was saying in the first place, right? And the second place. So at the end of the day, in the beginning of the next, systemic racism and discrimination are what cause underlying health conditions over generations and generations. And to your point, I just want to say that as the only Governor Northam had the clairvoyance to say, we need a chief diversity officer to really think about policy across all the secretariats. And in the same way, likewise, he said, we need a health equity working group and a leadership team to lead that group so that he already knew there was going to be a disparate impact for communities of color, particularly the Black community and the Hispanic and Latino community. And might I add, while Latinos make up the majority of positive cases, what we know is that the Black community makes up most of the deaths in the Commonwealth of Virginia. And so this is not to go into some type of discrimination Olympics, because my pain is your pain and your pain is my pain. And so as long as we think about it in that way, we can all take care of each other. But I just wanted to suggest and talk a little bit about what Dr. Danner was mentioning, in the sense that we've got to have a change of mindset. When we think about housing as being one of the number one social determinants of health, and the redlining that happened starting in the 1920s, I want to take it back even further. Let's take it back to the Homestead Act. And for all those that are watching, I want you to Google it. I'm not even going to tell you what it is. Look up the Homestead Act and figure out why at the time of when we were settling this country, why whites were given the opportunity to bring their families over. They were given money. It was the first social welfare program where wealth could be built generationally. And I would surmise that that's where we began to have this idea of wealth inequality. But even beyond that, today, just about an hour ago, I am so proud to announce to everyone who's watching, in case you didn't hear, not only are we taking down Robert E. Lee and giving local control over the removal of Confederate symbols, we're also finally identifying Juneteenth as a paid state holiday. So all of you who are employees of Old Dominion University and all those who are watching, you get Juneteenth off from now on. And we haven't passed legislation, the governor has decided to start as of this Friday. So make your plans to celebrate a second type of independence, because we know that July 4th, we weren't all free in 1776. And so we've got to think about it in terms of how do we make the Commonwealth and the nation more equitable and inclusive? And what does that mean? How do we interrupt systems? So the Health Equity Working Group and the task force and my office is thinking about how do we protect communities of color and those who don't have the privilege of social distancing and all of that. But also, hear me when I say this, simultaneously interrupting systems of oppression that have long been celebrated in the Commonwealth of Virginia. In 1619, slavery started for our nation right here in Virginia, not far from where you are, Dr. Valika Gatling. We've got to reckon with that. You know, we've got to understand that that is our shared history. And if we're not willing to roll up our sleeves and do something about it, then we're part of the problem and we're part of the oppressors. If you don't want to talk about it, that silence means that you're part of the problem. When the Northern administration, we are talking about it, we are reckoning with it, and we are doing something about it. And so that's what I mean, that we've got to do both. We've got to respond to COVID-19, and we've got to dismantle systems of oppression. And so that's what we're doing. And right now, we have a whole agenda that I would say the most historic equity legislative agenda in 2020 that just passed. It feels like a year ago, but it was only a few months ago. We have so much more work to do. There'll be a special session in August, and then we have the 2021 session, General Assembly session coming up. And while right now we're dealing with symbols, we have monuments of inequity with regard to housing and education and healthcare. But what we're going to be doing now is we're going to tackle those in big ways. So I invite everyone to go to my website and go to the governor's website and learn about how we're really interrupting systems of inequity, which include healthcare, and why we see the disproportionate impact in Black and Brown and Indigenous Native communities.
Thank you, Dr. Underwood. Dr. Martin, I'm going to come to you just a moment, but I did want to capture just a few points as I get to you, Dr. Martin. And so in the polling question, we know that there was information that people responded to that related to what they, maybe perceive. And we've talked about those things that are both real and those things that are perceived as it relates to persons of color. And so I'd like to start with you, Dr. Martin, in terms of what are some things, Dr. Underwood spoke to the fact that, people can research about history. But when we think about this notion of weathering and the stress that comes across those Black Americans as they face health inequities, are there things that come to mind that you can provide in terms of resources and or strategies or coping mechanisms? And I'll start with you and definitely give your other colleagues an opportunity to expound upon those.
Well, the first thing I'd like to say is that perceived barriers are real barriers. Those barriers exist for folks, and who are we to say that a barrier is a perception as opposed to a reality? And the bottom line is that if an individual feels that a barrier exists, the outcome is the same as whether or not someone thinks it's real, which is a lack of action or delayed action. So we have to keep that in mind, to think about barriers as barriers. whether a person feels they're real or not, it is going to change the way they approach healthcare. Throughout our conversation, the panelists have brought up social determinants of health. Again, those conditions where we are born, grow, live, work, play, socioeconomic status, education, neighborhood built environment. So all of these determinants work to help or hinder a person in their quest for help. But what I would also like to say is that this puts the onus on the individual for change when there are really many more factors that influence our health. If you think about something like the Center for Disease Control's social ecological model, there are many, many factors that influence health behavior as well. So if you think about it as the layers of an onion, for instance, the individual is at the centerpiece and the individual behavior is at its core. And we saw on the poll that many people, both healthcare providers and otherwise, feel that the individual behavior is the most important piece. And yes, this is where the action occurs. But before you can even get to the individual pieces of it, you have other influences that heavily influence the behavior. So you have your individual at the core, but then you have interpersonal factors that influence health. You have community support structures and programs that influence health. You have organizational policies, and then you also have policies at the societal level. So I think when we begin to talk about how can we begin to address these health inequities, we really have to flip our perspective on its head and discontinue our desire to begin with the individual and start looking at the societal and organizational influences on that individual. Because if I'm an onion and I'm at the center of that core, I can't bust out of those other layers without somebody removing those influences or those impacting factors. Now, if a person is able to work through those compounding layers, minorities are often also met with implicit biases after we have somewhat tackled those social and political barriers. So we've made it to the doctor's office, we've made it to our care provider. But now studies have shown that implicit bias does lead to disparate treatment. So minorities are less likely to get testing and treatment. We are more likely to receive lower quality care. We're more likely to receive less desirable services. So things such as amputations and hysterectomies, as opposed to being offered other types of treatments. And then we have higher mortality rates as well. So the bottom line is that multiple barriers do exist for minorities, but we have to peel back those layers with things such as the Health Equity Task Force and policies that Dr. Janice Underwood discussed to begin helping people to address their health.
Thank you so much. I have a question, and this leads it right. It's a great segue, Dr. Martin, for which we're just talking about in terms of health education. I'd like to read this question. It's, what role does health education, or the lack thereof, play into the perpetuation of health disparities? Should schools look to incorporate topics such as health disparities, food deserts, and other culturally relevant topics pertaining to healthcare in the curriculum to ensure that communities of color are aware of environmental factors that adversely impact them?
I don't know if that question was for me, but I would like to speak up on that.
Okay.
At ODU, in particular at the School of Nursing, we have a full year of interactions with the community in our community health courses. So for nursing programs, it's very important to have those longitudinal experiences where you're really getting out into the community and you're working with individuals from various backgrounds to enhance your education and your knowledge that you receive from textbook learning. So one of the ways that we're doing that at the School of Nursing is through our Population Health Learning Hub, which gets people in with the food bank and gets our students in at ambulatory care centers and with home health visiting organizations. So that puts the students right in front of the individuals that we're trying to help and provides them with a different level of education than simply adding a quick module to your course.
Thank you, Dr. Martin. And I was I was thinking, and I'll have Dr. Holing to expound upon that, but I remember as a building principal having, this salad bar, integrated into elementary school, and students learning different fruits and vegetables that they had never had exposure to, and going home and telling their parents, we got to go find a kiwi, and so I'll ask Dr. Holing to expound upon that.
Thank you, Dr. Getling. Yeah, absolutely. I think health education, the Virginia Department of Education has standards of learning related to health education, and certainly that is an avenue through some structural change of what those objectives, learning objectives are for each grade level. I think when we think about what does this look like in real life, certainly there's no structural change without meeting immediate needs. And so we do have to, like Dr. Camara Jones always says, we have to be willing to ask, how is racism operating here? And within context to what we're learning, whether it's history or math or science or whatever it might be, because those underlying social patterning of resources is what is driving health inequities and what underlies sort of the quality of what we experience and what others don't experience. I always kind of come back to something that Dr. Ariana Planey says is racism is not a social determinant of health. Racism is a root cause of the social arrangements that allocate life to some and premature death to others. And so when we talk about food deserts, actually something that I study, and I'm working in a community here in York County, Virginia, that has been experienced to long-term systemic historical injustice of land seizure, where there was an agrarian economy and there was community and there was education and there was life, and it was ripped away. And so the historical patterning of these lack of resources has perpetuated the food desert in this area that I'm studying, working with the community to try to come up with strategies for structural change. So in terms of education, absolutely, I think there is more that can be done. Our students in Virginia are smart and they're bright, and I think they want to look at these social issues and challenge them.
Thank you so much. So here locally, Save a Lot is closing on Saturday, right here in the St. Paul's community. And I saw a Facebook post earlier today that Angela Graves, who represents that area, is reaching out to get some expertise in that space to be able to problem solve, what to do. So she might be watching. I'd like to, I want to kind of move into a call to action. So, if we can kind of think about, so what now what, what can we do? And many of you have alluded to many things, but before we get into this call to action, which will help to definitely spur the conversation for those who want to be allies and advocates in this work. We do have a question, and I'd like to have Dr. Adams-Tuff to start us off on this, and anyone else can jump in with an answer. We have this from a participant. As a white male nursing student, how can I use my privilege to advocate for my patients of color?
Well, we've talked about education today. So it starts in your nursing education and in your own education of yourself, because often in traditional educational systems, we don't get a full picture of the context in which we are going to practice in. Such as people just told me this week, they didn't know what happened in Tulsa, Oklahoma in the 1930s, that in our own country, such a massacre happened, but it's not taught in schools. So educate yourself. And then with that knowledge, don't sit with it, but use data, research, and science to educate others and to advocate others. And so when I'm saying advocate, it means also using your privilege and your voice, and sometimes having to step out there courageously on the behalf of someone else.
Okay, thank you. We have another question. Let's see. I'm a nursing professor. I'm teaching community and public health. We cover this content in my course, but the challenge has been to get it integrated into other courses. partly due to us needing to meet the expectations of the license exam. What guidance or input about affecting change in nursing education could you offer? And who'd like to begin to respond to that, or maybe?
I think I can speak to that.
Okay.
I think that the first thing you have to do is come to a meeting of minds with your faculty and with your leadership. Because the fact of the matter is that yes, it is difficult to integrate additional content when you know that you have testing requirements and those that content that you need to meet for testing. But the other fact of the matter is that when you provide only care or only experiences in nursing education that are from the hospital or the tertiary care point of view, you're really only addressing a portion of that individual's overall picture. And so I think that you as a professor or an educator have to plead the case with your coworkers that this is an important piece of education for our students that needs to occur. The other thing that you can do is that sometimes you don't have to add content, you just replace. So for instance, at ODU, we are working on a project called Vet PRN, where we are getting out into the community, but we are also educating our students on primary care issues. Now we know that there's not a lot of primary care content in the NCLEX, but as opposed to taking away content from other courses, we're simply saying, where does this content exist? Because we know that it's threaded throughout the curriculum. How can we highlight those pieces of the curriculum, looking at primary care and community health? What kinds of funding is out there in order to implement programs for students that we can then get them out into the community more? So it is difficult to meet all of the different needs, but there's definitely a way that it can be done. And I'm happy to answer any emails or chat with anyone about the ways that we've done this at ODU, if you'd like.
Okay.
Dr.
Thank you. Yes.
Can I just make a mention?
Please do.
In the New England Journal of Medicine this week, there was an article published called Stolen Breaths. And in that article, there were 5 practices proposed. So as it kind of relates, one of the practices was around mastering the health effects of structural racism as a professional competency. So as all of the clinical programming or public health programs, are looking at this, how do we integrate into our licensing and accreditation and qualifying procedures an essential professional competency that acknowledges structural racism within the field? So I do think that's an actionable item, or policy that could be implemented.
Thank you. Thank you so much. I'd like to continue on with our call to action. And I'd like to start with Sable K. Nelson and provide us with some insights for call to action and some final thoughts as you've been listening to our panel discuss here today and hearing some of the questions.
Absolutely. First of all, my spirit has been filled by the conversation that we've been having, and I'm hoping that other people will be encouraged to share what they've learned here with other individuals. Don't just keep this to yourself, spread the information that you've learned, and also take this as an opportunity to grow and expand what you know as well. I just wanted to, before we depart, share with you all that there is an incredible app. I have it here on my phone, but it's the COVID Virginia app. I see that there were a couple of questions about how do we handle stress and what do we do about connecting different people to resources. So one of my final closing thoughts was to tell people to the extent that they can to download the app, the COVID Virginia app, and you also could go to covid.virginia.gov and it will link individuals, businesses to resources, depending on which of those categories, and it connects people to mental health services, to food services if people have concerns about being able to pay for their utilities. And the biggest thing that I wanted to impart upon people before they go is to take care of yourself, take care of your community, because we need everyone in this fight, and we can't do this fight if we burn ourselves out trying to fight the fight. So do what we can to take care of each other. Stay safe at home for as much as you can, but when you go out, wear a mask. And thank you again for this opportunity today.
Thank you. Mona?
I'd like to say that if you're comfortable, be prepared to be uncomfortable and be prepared to take on some new ideas. Racism is not a natural fact. It's a socially constructed fact, and we can change it. We can change the reality. It does require, if you're very comfortable, if you have a legacy of privilege, it might require sharing those privileges with other people. And rather than hoarding opportunities, we need to share them with everyone. And so I really advocate that, particularly for white people or people of any race who are wealthy, it's time to share the bounty of the privilege, both at the individual level and also be prepared to share it structurally. Housing does not need to be racially segregated. We've set it up in a way so that it is, but we can change that.
Thank you. Jamila?
Sorry, I was muted. I would agree with Dr. Danner. You have to push beyond your cultural comfort zone. It's okay to focus on these issues. It is okay to have it at the forefront of your mind as you go about your day, in your daily life, and at work. And I think that that's what's going to be necessary in order to affect change. I also want to encourage people to be loud about the need for diversifying your workplace and diversifying other areas where you work, play, and live. The voices are needed on these panels in organizations, in policy. The voices are needed, and the best person to speak for their needs is the person from that community. So please, I just encourage you to be loud. Again, as Sable said, I thank you for this opportunity. And I'm looking forward to what we're going to accomplish in the coming years.
All right, thank you. Leslie, and then Kim, and then naturally, Dr. Underwood, have the final say.
So I am just so grateful to be a part of this panel today. And I echo Dr. Martin's comments that I can't wait to see what comes from this. And what I would really love to see happen are those upstream approaches, that we move towards universal health care and social care, that we be about Social Security and workers' rights, that we have transparent data governance where we can link data together with social factors and health outcomes, and we work together in a collective impact approach so that we drive positive change on those health outcomes. And we're going to be faced with some tough decisions. I think there needs to be some desegregation and reinvestment within the healthcare workforce and with the public health workforce. And when a vaccine is finally available for COVID-19, we need to roll it out, and starting with the most, I hate the word vulnerable, but I'll use it, but most exposed perhaps or impacted populations. And that we need to do better and do right, and be unashamed about calling that out by and an unapologetic and saying, nope, this is where we're starting because we know where we need to start. So.
All right, Kimberly?
I'd just like to echo, thank you for allowing me to be part of this, as we say in Pilates, this meaningful discussion, and it has been very meaningful. As far as a call to arms, I would echo what everyone else is saying, and what we're really talking about are policy changes. And for me in my career, that's where you get the most bang for your buck, because so we have to arm ourselves with knowledge. Maybe we can provide this to the audience, or a link to the article that was published last Friday that factored out diabetes, all the diseases, age, income, and education and wealth, and still found that counties that have more of a higher percentage of Black populations have higher death rates from COVID. And we haven't gotten to the reason for that today, but there is a reason. And it is related to systemic and structural racism that results in what our federal government calls unequal treatment. Okay, and so once we know that, then we go and we talk to our policymakers about that. We provide them with that data, that evidence, and then we tell them what we suggest are some potential solutions. And redlining is still in effect today. There's been stuff all over about that, so we'll talk about that. Thank you.
Thank you. I think that's a wonderful idea to have that as a resource. I think that you'll have some folks who will be reaching out to you as a result of some of the questions that we saw. All right, Dr. Underwood.
Well, thank you for again having me, and I'd just like to end by saying that for everyone who's watching, you should take comfort in knowing that there are dedicated, laser-focused people at your university and at the state level in Richmond who are thinking about these issues and thinking the solutions through. I honor Sable K. Nelson, Curtis Brown, Dr. Lauren Powell, and Alacia Hackett, who are on my team, and the entire membership of the Health Equity Working Group. We collectively say to you, wear a mask when you go out as well, if you have to go out. You're protecting yourself and you're protecting others. So please wear a mask. This is not something that we should politicize. It is a public health crisis, and COVID-19 is a public health crisis. But I'd also like to submit to everyone who's watching is that institutional instructional racism is a public health crisis larger and more systemic than even COVID-19. And because of it, that's why we see the disparate impact in communities of color that have traditionally been and historically been marginalized and disenfranchised and under-resourced. And so it's with that spirit that we work every day, that I work 20 hours a day. And this team that we've assembled works tirelessly to dismantle systems of oppression. And so I understand why what we're doing in terms of COVID-19, but I also understand those protesters out in the street. And I want you to know that we hear you. In fact, I've been out in those Black Lives Matter protests, socially distanced, wearing a mask, using hand sanitizer, and I've been tested twice. And so I encourage you that if you are going to be in those protests, please take precautions. Please understand that this is a public health crisis and you could be saving your own life. So wear a mask, use hand sanitizer if you're in those protests, and please get tested. To Dr. Hoglin's point that even when we have a vaccine, family, you need to understand that the issues for which we are dealing with will make some communities not trust not only the test, but the vaccine. And so we understand that. And we're doing everything we can to dismantle even those rightly fears, right? Those justified fears in communities of color that they have against the healthcare system and the government. And so we're part of your team. We are One Virginia, and I'm looking forward to rolling up my sleeves and getting to work with you. Thank you so much, and thank you for having us.
Thank you. Thank you to everyone. Thank you so much to our distinguished panel of experts and our attendees. We hope that you have enjoyed this discussion and that it will indeed be a catalyst for change. If you would please take a moment to fill out the survey that's going to be sent to you immediately after this, we would greatly appreciate it. Also, this particular event was streamed on the Old Dominion University's community events page. And so if you did have someone who was not able to see it and or you want to utilize it for future use, it will be available there. And so we thank you so much on behalf of President Broderick and our whole Old Dominion community. We thank you so much for being with us today. And we look forward to hosting other events where we can provide opportunities for you to be informed and educated. Thank you.